Hi everyone, welcome to our final session for the first aid workshops. The first 3 sessions are on YouTube, so if you subscribe to our channel, you can watch them there. The aim of these is just to give you guys knowledge on how to deal with first aid situations if you may encounter them. This isn't a certified course, but we have done a lot of research and we do have trained and experienced people teaching them. So for today's session, we have Paul, who will be going through severe bleeds and fractures, and Amirah, who will be going over dental emergencies. So over to you, Paul.
All right, let me unmute myself first. That's not it. One second, that's just me being incompetent. There we are. Okay, so I'm going to be covering bleeding. So I'm Paul, I'm a 4th year medical student. I also have the background of I'm an A&E nurse by trade, so I have seen a lot of bleeding. So I'm hoping I can impart just a little bit of knowledge onto you about what you can do if you encounter somebody who's severely bleeding. Obviously, I'm only going to cover a small fraction of bleeding, but there's only so much you can do. You know, if you encounter somebody on the street in your civvy clothes. So okay, let's just get this. So common types of bleeding. So obviously the 3 most common types of bleeding are first traumatic bleeding, aka you're hit by a car, your hand gets chopped off, trauma. You've got obviously obstetric bleeding, pregnant ladies, and gastrointestinal bleeding. This talk will mostly be covering traumatic bleeding because that is the sort of, it's essentially one of the sort of simpler ones, and it's one you can actually do something about. If pregnant lady is having hemorrhage, all you can do is call for help and just do what we've seen in other of assessing for signs of shock. It's the same with gastrointestinal. There isn't much you can actually do if somebody's vomiting up frank red blood. You can just position them correctly, call for help. So what we're going to do is mostly talk about traumatic bleeding. So in traumatic bleeding, there's an old moniker of on the floor and 4 more. These are the common places that you will put large volumes of blood. First one is obviously is your chest, your abdomen, your pelvis, and then actually into your long bones, like the compartment, your femoral compartments can hold over 1 liter of blood each. So that's a lot, especially if you've got bilateral femur fractures, you could potentially lose 2 liters of blood, which is rather a lot. So obviously, as you can see, chest, abdomen, and pelvis, your thorax, that big, mostly hollow cavity full of nice squishy organs that blood can flow into. So what can you do? If somebody has a bleed, what you can mostly deal with is extremity hemorrhage, aka arms and legs. That's what you can easily manipulate. That's what you can compress. If somebody is bleeding into their chest, all you can do is the second stage, which is early recognition. Is this person having difficulty in breathing? Is this person going cyanotic? Have they got, one-sided chest rise? Have they got a deviated trachea? If they do, all you can essentially do is recognize that. You cannot be placing chest tubes and things like that. You're not qualified, you don't have the kit. So most of the stuff you can do is around compressible extremity hemorrhage, early recognition. Other one is history. If a person gets hit by a HGV and you happen to be the first person there, think to yourself, rather than the next part, which is about safety, there is a good chance you may be the last person to talk to this person before they lose consciousness, they arrest, all of these things. So you need to try and elicit what history you can from them. Now, if you watch them get hit, you know that, but what if they don't have any ID in their pocket? It's worth finding out. What's their name? What's their date of birth? Have you got any medical problems? If it turns out they've actually got a factor 7 deficiency, that could be worth knowing if they're going to bleed a lot. Are they allergic to anything? If they turn around and you say, I'm allergic to morphine and penicillin, two things they stand a very good chance of getting very soon, it's worth knowing. So try and elicit some history from them. And the other one is safety. You got to think, like, first safety is your own. You're walking down the road, a mother pushing a buggy gets wiped out by a bus. Your first thought should not be to run out there, because you, looking tunnel visioned, run out there and the guy that's overtaking the bus that has stopped decides to run you over. So safety for yourself and also safety for others. I'm from Cornwall. There are a lot of RTCs there on fast A roads with blind corners. So if you come across a car wreck, you've got to think, is somebody driving up behind you at 60 miles an hour and going to end up ploughing in? Obviously, as well, if there's a car's involved, is the engine turned off? Is the handbrake applied? Because the last thing you want to do is go and try to help somebody and then realize the car's rolling back down the road. So these are the things that you can do. The most important thing when it comes to stopping bleeding, and what's the biggest moniker for everybody involved in trauma, is preserve, do not replace. The best place for a patient's blood is circulating, not on the floor. Replacing blood is something we can do, but it is never as good as the perfectly good physiological blood that you have. So preserve, don't replace. And what you can do is what's known as DDIT. The first one is direct pressure. Maybe you don't have gloves. Like me personally, I always got these in my bag, because you stop to help somebody, you do not know if they have hepatitis, HIV, or anything like that, that you don't end up accidentally catching. So direct pressure, you can take everything, palm of your hand, the Mark 1 fist, and just push it onto this extremity hemorrhage. If they've got, say they're bleeding from a femoral laceration, you can just direct pressure on it. Ideally, you'd want to use like some sterilized dressing and just press on that. The second D is double direct. If you're pressing on it and it's bleeding through, you want to press something else on top of that. So you're putting twice the amount of pressure. One thing you do not want to do is keep removing it to check, because blood coagulating, it may well be clotting and you're pulling it off to look every time. The next is I, which is indirect pressure. If they have a femoral injury and you are pressing on it as hard as you can and it's still bleeding, you may have to go for indirect pressure, as in, where does the femoral artery come close to the surface, sort of the inguinal canal? You may need to get your hand and press on the inguinal canal and directly on there. That can help stem bleeding. Elevation, blood won't pump as well against gravity. If you have a distal wrist injury, say somebody's accidentally cut their wrist, however, pressing on it and elevating it may well stop it. And the final one, T, is tourniquet. So you can put a tourniquet on. These are, one, incredibly painful. I've had a tourniquet put on properly for a demonstration and it was horrible. So any tourniquet people put on is generally incredibly painful. And 1 second. Let me just, how can I make myself, okay, 1 second. So I'm going to, this is a soft T-wide tourniquet. This is what I'm talking about when it comes to wrapping a tourniquet on it. Round the limb, cinch it down incredibly tight as you can. And then you use, this here is steel windlass, and you can then turn it until essentially the blood stops flowing. Then you lock it in place. Important things to take into account. There, you write the time. If because you need to know how long this tourniquet has been on for. So surgeons and people down the road know how much time they have. Okay, let's get back to the PowerPoint. Yeah, so you can use tourniquets. The best thing is a proper tourniquet like that. You can try and rig a tourniquet, but all the research shows that the average time it took for anyone to rig a tourniquet is about 4 minutes. You can lose a litre a minute, so that you're 4 litres behind. And also that will only work for upper limb extremities. Your quad and your hamstring, your feet, if you want to isolate a femur, it's not happening. No one has ever managed to ghetto a tourniquet. So either you carry a tourniquet or you don't. If you can ghetto it, that's your choice, but it's probably not going to work. And these are additional considerations. There's another old saying in trauma: the first clot is the best clot. You do not want to, if somebody's got multiple system injury, they've become hypotensive, they've clotted off, they're currently quite stable, and you pick them up roughly and dislodge that clot, they start bleeding. So the first clot is the best clot. Handle them gently. Second one is keeping them warm. And also in trauma, there's what's known as the triad of death, because it's one, it sounds very dramatic, and two, it's very true. Hypothermia, acidosis, coagulopathy. Patients that get these generally tend to die because they self-perpetuate each other, and there is essentially, it becomes irreversible and they die. So what can you do about acidosis? You can keep the blood inside them. What can you do about the coagulopathy? Keep the blood inside them. What can you do about the hypothermia? Keep them warm. There's only so much you can do, but you've got to give it a try. Warm them up however you think you can. Put something over them. Even if you've got one of those sort of space blankets, anything is better than nothing. And the volume location issue. Somebody severs an arm off, it's very, very dramatic, but it's also very, very manageable. Somebody starts bleeding, somewhere slightly more occult, it's a lot more difficult. Volume is not the most scary thing. Somebody has a cardiac injury and is tamponading. That's not very much fluid, but it can also tamponade the heart, so they go into an asystolic arrest. They can bleed from their tonsils, like a post-tonsillectomy bleeding. They're essentially bleeding arterially into their own airway. So that's another consideration, is just because there's not that much of it doesn't mean it's very, very scary. And I believe that's it for hemorrhage. Next, we're going to go into fractures. Oh, my bad. Okay, fractures, and it's still me. In this, and again, in this, we will mostly be covering limb fractures, because pelvic fractures are, one, incredibly complicated, and two, I only have one piece of advice. If you suspect a pelvic fracture, one, you immediately call for help and you tell them, I suspect this person has a pelvic fracture, and you keep them still, incredibly still, because obviously the pelvic ring has, the aorta goes into it, then bifurcates into those two great vessels. And if you break your pelvis, you've got all those nerves, all that vasculature. It is incredibly, incredibly scary. Just keep them very, very still. And if you suspect a pelvic break, you've got to think the pelvic ring, you break a circle, you can't break a circle in one place, especially a solid circle. It's broken in two places. So pelvic fracture is very scary. Spinal fractures. For this, again, it's exactly the same. You suspect a spinal fracture, you keep them completely still. Here, you can do things like assess their neurology, but most of the thing you're going to be doing is keeping them incredibly still. And the other one we won't be covering is facial fractures, because there's not a great deal you can do on the side of a road with somebody with a facial fracture. if they have a Lefort fracture or anything like that, essentially all you can try and do is manage their airway, manage them, and get as much cavalry in as possible. So when it comes to limb fractures, here are the types of limb fracture. You have sort of the classic closed fracture, which is just a fracture that has not opened. Next to it, obviously, you have an open fracture where the bone has obviously gone out through the skin. It's open to the air. These people are at very high risk of infection, osteomyelitis, all manner of bad, side effects of the fracture. So for them, it's not much of a fracture. You've also got you have the transverse fracture, which means it's transverse, means basically it's 90 degrees, cuts straight across 90 degrees. You have a spiral fracture, which is essentially when it's twisted like this. So that's classically somebody gets their foot caught in something and they're turning, and you can spiral fracture your tibia or your fibia. You have a comminuted fracture, which is essentially when it's not broken into just two bits. So you have various other fragments. You have an impacted fracture, which a lot of the time is just a non sort of open fracture, which essentially is broken, then driven into itself and basically sort of mushroomed out a bit. So it's basically jammed the two ends together. You have a green stick fracture where it's only broken on one side. This only happens in children because obviously their plates haven't formed properly yet and their bones are still a bit sort of malleable. So that's the only time you'll get a green stick fracture. And an oblique fracture, which is the opposite of a transverse, as in it's fractured, but it doesn't go at 90 degrees. It's maybe off at an angle, or maybe it's sort of ridged. So those are the sort of main types of fracture. Assessment, this is what you can look. So the classic one is look, feel, move. Obviously, you can't really do all of these things in certain places. If you think somebody's got a fracture of an elbow or something, you only don't want to move it, and more importantly, I don't think the person who has it will want you to or let you. So you can look for a wound. Is there a pre-tibial? If somebody has had a car gone into their shins, very low car, have they got a pre-tibial laceration, which gives you a high index of suspicion for maybe a fracture underneath? Obvious deformity. Is their foot facing the wrong way? That's a very obvious sign that they've got a fracture. Then you can look at color and perfusion. There we are looking at the vasculature, like if it's cold, if it looks, I mean, if they've got like one-sided injury, if they've got a sort of, unilateral injury, it's easy to do because they have a control leg next door. So you can look at the leg. Do both legs look the same color? You can feel it. You feel for, okay, if I press here, does it hurt? No. If I press here and they start screaming, that bit clearly hurts. So you've also got crepitus. If you feel it and it feels sort of crispy, sort of like Rice Krispies or bubble wrap, sort of crepitations, like the sort of sound you hear when you auscultate lungs. You can press that and you can hear that. That can be a sign of sort of soft tissue disruption underneath. Air. You have temperature. Like that's again is looking at the vascular supply. Is the temperature the same? And obviously pulses. If they have a humeral fracture, you can assess the pulse here, because if they've got a pulse here, that means the blood's getting passed. That means you've got a perfused limb. And obviously you could do the move, which is looking at joint stability, but a lot of the time I wouldn't do that unless you're one, very competent, or two, very confident that they don't have like an intra-articular joint issue, a neck of femur fracture, because moving it could potentially aggravate it. So sort of interventions that you can do. You can do a neurovascular assessment, a very, very quick neurovascular assessment. The 6 Ps of the ischemic limb, which are, I should have really written them on there, shouldn't I? But so the 6 Ps of the ischemic limb are pain, pallor. So pain, is it painful? Pallor, the color. Pulse, is the pulse there? You also have paresthesia and paralysis. Can they move it? Can they feel it? And the 6th P is perishingly cold. So you're looking at, that is looking at the vascular supply. If somebody has a I don't know, a knee dislocation, which is an orthopedic emergency. There's nothing much you can do about that. But if they've got a cold, pulseless foot, you can suspect that the blood supply is cut off. So that is something you need to relay to. If somebody else is on the phone to the ambulance, you need to relay this, because the ambulance person the other end will go, are they awake? Yes. Are they breathing? Yes. They're currently cussing because they've just been smashed in the knee. And they'll be like, okay, if you then turn around and say, tell them I think they've got an ischemic foot, instead of waiting 30, 40 minutes for an ambulance, you'll have one flying there on blue lights because there's potentially a limb at risk. So that's what you can do. Also, neuro assessment. So just because the vasculature is intact doesn't mean the nerves aren't intact. And you can do a quick sort of, somebody has damaged their forearm, you can do a quick assessment of the radial, medial, and ulnar nerve. Can they move all their fingers and their thumb? Can they flex their wrist? That means most of them are probably intact. It doesn't mean they're not damaged. It just means they're grossly intact. Immobilization. Like I said, if somebody's got a fractured wrist or even a fractured, fractured radius, a lot of the time they will self-immobilize it. They will hold it close to their body, hold onto it and not let you go anywhere near it, which is good. It's immobilized. But you can do a neuro assessment, a vascular assessment on their fingertips and say, just wiggle your fingers, just let me press on your fingernails, let me touch your, let me go for that radial pulse. So keep it immobilized. Like if you think they've got a fracture, maybe they've got a femoral fracture and there's no help coming soon, like in theory, there's no reason you can't bind their legs together at the ankles. That will immobilize this leg a bit. Likelihood is they're going to be immobilizing themselves and not let anybody be touching nothing. What you also reassure the patient, somebody's got a badly broken leg, you can say, look, as far as I can tell, like your blood supply to your foot is still good. The nerves still seem to be grossly intact. So that's something else. And also, like I said before, you can escalate, because just because the blood supply is good now doesn't mean the blood supply won't change. They've got an expanding compartmentalized hematoma in their leg that ends up cutting off that femoral artery, and you watching that foot and all of a sudden it's like, oh, that's starting to change color a bit. You can feed that back to ambulance control, whoever, to say, look, this is a dynamic situation, send in the cavalry. And also, like I said, a lot of this is blind technique. I've seen people walk into the department. I saw an 80-year-old woman walk into an A&E department with her neck of femur broken and compressed by about 2 or 3 centimeters. One of her legs was markedly shorter than the other, and she came in walking with a limp. So if you see something's fractured, don't be thinking about doing fancy things like think, oh, if I pull that, I could relocate that, I might get the blood flow going again. Because if it looks like you can see there, you might be making it worse. It might not be, like, you just have to realize that you can't see everything that's happening. So just blindly doing anything may cause more problems. And yeah, that's pretty much it for bleeding and fractures. I'll hand you back to Uncle Billy.
Yeah, thanks, Paul. So now Amirah is going to be talking about dental emergencies. So yeah, over to you, Amirah.
Thank you. Hi, guys. So let me try and get. Here you go. Okay, so I'm going to talk about bleeding in dentistry as well. Although we do say that bleeding gum is a slow progressive disease, you know, but you guys have to make sure that you spot it at first and you try and fix it as soon as possible. Otherwise, you know, you can result in a tooth lost. So we're not going to look that pretty. Okay, so what are the causes? Usual poor oral hygiene, tobacco use, vitamin K and C deficiency, stress. Stress can make it more difficult, so that's why we can have some bleeding sometime. Or taking blood thinners, medications such as antidepressant, heart medication, even sometimes oral contraceptives, or any bleeding or diabetes or any hereditary diseases. We can have the most common obviously is an infection of the tooth or the gum due to plaque and caries, or sometimes very common are during pregnancy actually. They end up having pregnancy gingivitis, very common. And you also have mouth sores, one of the main common causes of bleeding. So how do we know? Sometimes it's just by brushing your teeth, or you know, you see blood all the time. So you know it's a bit bad when especially your gums become very soft, swollen. You know, you can see slight discoloration. They become more reddish compared to the other part of your gum. Or you know, sometimes if you're eating, suddenly you can taste the iron. I don't know how you taste, but we say we taste iron in our mouth. Sometimes you can have a pain if you're eating something, you have a sharp pain, you're like, oops, what's happening? You feel it, and you have bad breath as well. Obviously, someone, hopefully a friend tells you, hey, excuse me, have bad breath. You can hopefully have a look and see where it's coming from. So usually, if you're bleeding a lot, the most common that we tend to do is we apply pressure. So we used even ice water, or you can use your clean hands first, and then just apply pressure and you make sure it stops bleeding. The next thing is, yes, it's bleeding, but you also have to make sure that you're cleaning the area. Sometimes it could be a food stuck in your mouth, or, you know, it can be just bacteria, plaque and everything. So by regularly brushing, you know, you'll eventually know if it's actually a simple cause that's doing this or something further. You also have deficiency. We all know this. Vitamin C, if sometimes you can see it's a bit more reddish, or, you know, then you have to be a bit careful. Some people do like to have a fizzy drink or juice, and it can aggravate it. So whenever you start to have bleeding, try to make sure you avoid those at the beginning. And okay, these are dentures for hopefully not any of us, but sometimes they can bleed. So what you do is you only wear them whilst you're eating, and then you can go to the dentist later on and see what's the issue, why they're bleeding. And also, because your gums are sore, you do not want to brush vigorously. You want something very soft that will help take out the debris or take out anything, but also to make sure you're protecting your gum. And I always tell anyone, rinse your mouth with lukewarm salt water. They're the best disinfectant, or hydrogen peroxide. That's some people do that, very little concentration, and water. But the best is with salt water. How can you care? So, you know, best thing is we should brush our teeth at least for 2 minutes twice a day, if you can, 3 times a day. And like I mentioned before, we should not aggressively brush our teeth. This will damage your soft tissue, your gum, even more than you should. And what you can do is you should be flossing. A lot of people, you know, I have issues where my teeth are connected. So it's very hard, but this is why I floss a bit more than usual. So you have to make sure so then it doesn't lead to more bleeding or more the serious cause later on. Again, rinse with warm salt water, and stay away from smoking and tobacco. When you have the bleeding, make sure you take care of these oral hygiene first, and then eventually you have a look. In case it keeps happening, it could be something else. It might not be oral hygiene, it might be something more serious. Then you have to go to the dentist. They will know a bit more. What they're more likely to do is do a blood test. You know, some people with diabetes or, you know, heart patient take aspirin. Those, will prevent the clotting of your blood. So therefore, if it's a bit more dangerous, and then definitely you go to your doctor and they will recommend you what to do. That's it for bleeding. There's not much for dentistry, to be honest. The next one we'll talk about is tooth loss. Okay, so a broken tooth and the loss of permanent tooth. So usually a knockout tooth happens during a fight or, accidents, or, what else can you, like those during trauma, most likely. So your tooth is knocked out. What we recommend to do is wash your mouth and your tooth with water very gently, is to make sure you don't have any of your saliva bacteria or anything surrounding trying to go inside your pockets. Otherwise, if any bacteria goes inside, and it can lead to further complications. So try and keep it clean as much as you can, and be sure to not touch anything. Do not touch any tissue. Try and remove it. It might be bothering you. Try and not touch anything. This is mainly for, loss of tooth. Otherwise, then you will have to go to the dentist, and they will do an X-ray and see how much damage, what are the, what else they can do, how they can fix your teeth. Can they put it back, or, depending on the health of your neighboring tooth, what treatment they can give to you. Most common are dental fractures, from playing football, from falling down, especially kids, we all hear. We have different types of emergencies depending on where exactly the area of where your tooth is fractured. So as you can see, we have different classes, 1, 2, and 3. And let's have a look. So the class 1 is where only the enamel portion of your tooth has been broken off. With this, there's not really any much emergency, only your enamel part is gone. So you won't feel any pain, you won't feel, it won't cause much damage to you. The only thing you might feel, if it's in the front or somewhere in the back with your tongue, it might, be sharp. So you might go there to your dentist and say, look, I just want to fix it. But again, it's not an emergency. Some people do, if you have some important project or something happen, you need to fix it, then you go to your dentist for aesthetic repair, obviously. Then let's talk about the second class. Second class, then, it's where it also involves your dentin. So you would be able to see this visually, because you know how our teeth is usually, we say, white or creamish. When it comes to the dentin, they're more yellowish. You'll be able to see this. So they are a bit more, they're softer, and they're more likely to let bacteria in. It's a softer area compared to your enamel. And it's also like the protein, the nutrients of the bacteria. Therefore, the bacteria will more likely go and they start spreading really quickly. So that's an emergency where you need to get this fixed as soon as possible. And usually we use a glass ionomer. The dentist would do that and will fix it depending again on your surrounding tooth and what you need and the treatment that need to be done. And you need to do an X-ray, and you need to examine the surrounding of your teeth to be able to give the best option for the patient. And the class 3 is the most, it will be painful. You get lots of bleeding. What we do is we control the bleeding again with a steroid gauze, or, you use, you have to cover the pulp. The pulp obviously is where you have your nerves and you have all your blood, and you do not want any bacteria to come into it. It will go inside your root, towards your gums, so it can go to your bones, and no, it's not going to look pretty at all, and it's going to hurt. So we try to do this as soon as possible. We'll use calcium hydroxide as a base to be able to cover the pulp again, but it has to be cleaned. So the dentists are more likely to refer you to an endodontic. So the treatment will be a root canal treatment for sure, where the most famous, the longest, and the most horrible part is it's long, and the dentist will try and clean the inside, make sure it's dry, and fill it up, and then they can put anything on top depending where and how much of a tooth loss you have. And it will be painful, but oral analgesic and topical will be I mean, oral will be prescribed, but topical will be avoided. That's it for this one. Where do I hit this? Okay, then we have the last part, which is severe toothache. Okay. When we talk about emergency in dentistry, this is what we talk about, severe toothache. Because no one likes the dentist, isn't it? It's only when you have the toothache you cannot bear that you call the dentist here. So we have different type of pain, but the most common where, you know, you'll give us a call in the middle of the night is the acute pulpitis, this one. So what would happen is, you know, you do have different type, like I mentioned. You have those where you feel the pain and some you might not feel the pain. You can have acute, you can have chronic. So at the beginning, you know, you'll have, you can detect sometimes if you're having sweet, or you can have cold and hot, you feel like a shock in your, oh, what's happening? Maybe it's nothing. So you tend to ignore it. And if you ever go to the dentist before that and they figure out what it is and they take away the cause, you won't feel the pain. However, if you keep ignoring it, you will suddenly have some sharp piercing, you know, shooting pain, like throbbing pain nonstop. It will affect you a lot. It will bother you. So this is where, I mean, you know, they be throbbing, you will feel it. And again, this time when you know, by heat and by cold, the pain will be sharper, you will feel it way more. And when you come to see the dentist or you go to an A&E, they will see how much of the cavity, and most of the time is secondary caries or acute caries, and we'll have to do an x-ray. The x-ray will tell us how much it has spread, where it has spread, especially if it's the root, it's done necrosis, and you know, and whenever we do percussion, so usually the dentist take the back of his mirror of his probe and then they just tap your tooth. And if it is very painful, you know, that's it, you know, you have inflammation there and it needs to be treated very, very quickly. The next thing that we tend to do is your vitality test. So some tooth, yes, it can cause a lot of pain, but it might just reach a little part of your pulp, so your tooth can be saved. But sometimes, you know, when it has affected your whole pulp, it means, unfortunately, your tooth is gone. It has to be removed. So how do we do this? We usually do a thermal test. Is we use a cold simulation. You would take a cotton bud or anything. We use a cold spray. So we put on a natural tooth first, so you have an idea how it should normally feel like, and then we'll put it on your affected tooth and you will feel the pain. So this is how we realize which one is affected or not. The next thing we do as well is an electric test. So you shouldn't feel, the current that we see should be very less for a healthy tooth. In case it has become necrotic, you'll have more current going through, and this is how we know if your pulp has been affected or not. So it depends again on your pulp exposures. For example, if it's a traumatic exposure, or you know, it's on the surface, then you can just do capping, where you just close off your pulp. You know, you clean up and you just close it off, and then depending again on how much your tooth is affected, either it's a crown or we can do a filling, depending again. Or if it is a caries and has affecting a lot of the area, then again, it's a root canal treatment. And that's about it, actually. There's not much with dentistry. If you guys have any question, please shoot.
Amirah, I actually have a question.
Yes.
I read somewhere, you know, if you lose a tooth, like if your tooth comes out, like you can usually just shove it back in. Is that true?
Yes, so this one, I tried to get a dentist to reply to me, and I read about this too, where if it falls out, you put in a glass of milk, and if you can clean the area quickly, but within 30 to 30 minutes is very little time, and then you can just press it. But I'm not sure how if it's effective or not. I tried to ask as many dentists, and they said, I'm sorry, we don't know about this. I've never heard of it, to be honest. Yeah, and I know some dentists did say, sometimes if your frontal tooth is chipped, you can glue it back together. A dentist did mention you can, but it won't be as strong as compared if you do a filling and you fix it together. So it depends on the dentist, or it depends on your age, probably. I guess if you're an old person, your bone has resorbed. If you pull back the tooth, it will fall back out. If you're a young person, I guess it'll be easier. And yeah, that's all I can say, to be honest.
Thank you. So yeah, thanks.
Thank you, guys.
So yeah, that concludes our session. This was our final session for the emergency workshops. They're all going to be uploaded onto our YouTube channel. We're trying to do more future events. So if there's anything you'd like to see, then let us know. So things like quizzes and debates where they're a bit more interactive, so you guys can get involved, or even more first aid sessions. So things we haven't covered, like psychiatric emergencies or pediatric emergencies. We can do things like that. So if you do want to see events, please let us know. You can email us or contact us on socials. One last thing as well, we are raising money for St. Nicholas's Day in Ukraine. Similarly to Christmas, it's a day of celebration and thanks and gift giving for Ukrainians. But unfortunately, there's a lot of vulnerable children and elderly people in nursing homes who don't have a lot. So we've set up a GoFundMe where we're raising funds to get them things like warm food and clothing. Details of that are on our Instagram, and we've sent out email about it as well. So if you can donate, that'd be great. Anything will help. Similarly, if you are in Ukraine at the moment, we are taking items. So if you have any spare clothes or food or stationery and toys for the children, that'd be great too. So yeah, again, details of that are all on our Instagram and email. So thank you all for joining. Stay safe.